hablo portugués, mi español no es lo mejor, pero yo voy a hablar en inglés para ser más fácil si no tiene problema. I'm very happy and thankful to be here to present, like part of our work and what have we been doing, and especially to show like some advantages and things that we're doing, in our lung transplant program, and how the lung transplant program and how the lung transplant in the world is changing. That perspective that before used to be a surgery that was very complicated and with low and poor outcomes. It's still complicated, but we'll be able to improve the outcomes and the results. Have no disclosures, and we're going to talk about ECMO and bridge to transplant and discuss what would be an ideal candidate for bridging and the risk factors that will be linked into the outcomes. And I would like to start with this case. It's a pretty bad x-ray. It's a patient, she's 28 years old, female cystic fibrosis, was presented with a FEV1 of 23%, had pseudomonas and part of her disease with pancreatic insufficiency, chronically malnourished, had a PAG, massive hemoptysis that need to be embolized 3 times, and had recurring exacerbations. And on March 2023, she came with respiratory failure, hemoptysis, and pneumothorax, and a persistent hypercapnia despite high ventilator settings. And this is the CT scan. And we think, is this patient an ECMO candidate? And when we say ECMO candidate, we always mention ECMO for what reason? We're bridging to what? We can use ECMO for recovery, and we can use ECMO as a bridge to transplant. And we know all the trials that showed ECMO for ARDS, but we can also make a bridge to decision to see how we are going to approach that patient in terms of candidacy. If we go to the consensus of how to select lung transplant candidates, by the International Society of Heart and Lung Transplantation, which is the society that is world-renowned. And one thing that we see is that the most important thing is to consider contraindications, and absolute is that most lung transplant programs should not transplant patients with risk factors that are expected under very exceptional or extenuating circumstances. Then we need to acknowledge what the program can actually do and see if it's going to be able to actually overcome those factors. And if you see the factors that have substantial risk for post-transplant outcomes are age, higher than 70 years old, patients with limited functional status with potential for post-transplant rehabilitation, patients with mycobacterial abscesses, and the use of extracorporeal life support, the use of ECMO. And what would be an ideal candidate? Of course, if you get a relatively young, robust patient with lung and only lung disease and has a support by family, that would be ideal, but not necessarily we see those patients, and then we need to start going and dive a little bit on those risks. Here, when we talk about age, about 70 years old, we can see that from and that varies by center, but if you get the US data from the SRTR, it's around 14% of the cases are done on patients that are older than 70 years old, and in our institution, our numbers are around 21, 22%, which is higher than in the state of Florida. And in this case, she was 28 years old, and going to the cystic fibrosis perspective, when she was, for the time of referral, ideally, we need to see those patients earlier with the intent to correct and manage the patient in a way that you can make them candidates for transplantation. But if we get a patient with FEV1 less than 40% and has one of those things described, these patients, they should be referred, and we should be seeing and considering them for lung transplantation. If we get on the selection of an adequate candidate, which I think is varies about center experience and the absence, of course, of contraindications, but you see that absolute contraindications are irreversible multi-organ damage, refractory bacteremia, septic shock, severe obstruction, vascular disease, contraindication to anticoagulation, and the ineligibility to lung transplantation. If we get all those, we can start seeing with centers with more experience, like they can get different parameters for what they actually think would be candidates that they can manage from an absolute contraindication to a relative one. In this study, if we see patients that were bridged to transplant and compare the survival of patients that were not bridged, the survival for the ECMO patients were a little bit, slightly lower than the ones that were not. And if you see, like, from a 1-year survival of 76% to 86%, of course, when you consider to bridge with ECMO for transplantation, you need to acknowledge that we're talking about the first transplant doing. Like, if you are considering for a retransplantation, you see that the survival rates just drop even more, and then that should be a decision, is a center decision to actually do that and carefully consider those patients. But when we get the candidate selection, bridge to transplant, that would be patients that would not consider would be the patients with multi-organ dysfunction, older than 65 years old, prolonged mechanical ventilation support, uncontrolled sepsis, a BMI higher than 30, with coronary artery disease or severe deconditioning. These are factors that are going to impact on the outcomes, and bridging those patients are not going to make those factors improve. If we get back to the patient and you see what would be the decision on a patient with these characteristics, with these images on the situation that she was presented. When we decided to cannulate this patient and manage bridging to a period that we're going to get her rehabilitated, better nutrition to get her to transplant. And of course, the question comes when we're bridging patients and what could go wrong. There's a lot of things that can go wrong. Patients can develop brain bleed, sepsis, clots, and the key part is try to make the cannulation to transplant or that bridge to decision the shortest possible. Why that is important? Because if you see that if we get the patients transplanted on a shorter period of time when they are bridged, there is if we get a cutoff of 14 days, you see that bridge to transplant that are done, before on these 14 days, they have better results and better survival compared to the one that are bridged for longer. And how can we shorten that arrow, to make things faster, is try to react and change things that we can actually change. One is make the transplant decision as closer to the bridge or to the decision to cannulate. Of course, avoid multi-organ transplants, like patient needs like lung, kidney, lung, liver, like we should avoid those. When you have patients with a small stature, we can have different techniques to do lobar transplantation or just tailor the lungs, bigger lungs to fit on the smaller cavities. Patients that are highly sensitized start with a desensitization protocol that you use, and which pretty much increase the number of lungs that can be used for that specific patient, and a donor pool optimization, which is what you can see, like since we start developing the lung transplant program at University of Miami, MTI. We are getting what is called, like a borderline donors, and be able to work with the OPOs to improve those organs and have like a more broadened spectrum of acceptance with patients that are smokers and elderly patients and lungs that are far away from us. And the other important thing is, on all these, having an experienced ICU team is very important, because the main goal for the ECMO support on those patients is to get them early extubated or with early tracheostomy, weaning their sedation and get them walking at the unit and exercising. And that even shows that have patients spontaneously breathing on ECMO, it's better than have patients that will be on the vent and ECMO for longer in a 3-year survival data. And from our experience, we're increasing the number of patients that are placed on ECMO for bridging to transplant. We are around 23%, and I think the interesting thing is just to show how things can be very hard for the patient and for the whole team. Like you have several people, like to get a patient walking on a patient that needs to be motivated to be doing what she is doing, to be able to exercise, and that gets like 5-7 people just to be with one patient to actually be able to get her through. But in this case, there was no absolute contraindication. She was young, was just lung failure. The bridge to transplant was a short time. She was walking and she was breathing by her own. And you see like this ECMO in lung transplantation trend is increasing, like not only the utilization of ECMO at the listing, but also ECMO at the time of transplant. And as we start getting used and being more cautious on how to use and stratify those patients, the utilization of ECMO is increasing year by year. And I think here is what I think it gets the important part. If you start checking the patients on different cohort times, you see that as cases are being added to the cohort and the understanding of how to manage those patients, the survival has been improving and getting better compared to what was done, like 10 or 15 years since 2000, for example. And in that case, we bridged to transplant. This is the patient on her discharge. You see that she, got a little gift, like, she has like 2 new pairs of lungs, one that she's breathing, the other one that she's going to bring home with all the, like all the messages that she got from the team. And here is, I think, is what makes us be very happy, and what moves us to do all this is she's celebrating her birthday, her 1 year, like after lung transplant. And here we have the Pulmonar team that just was celebrating with her, and then quite interestingly, I just find out after 1 year that she was my neighbor. Like we live in 2 towers. I live on Tower A and she lives on Tower B. And I had the chance to, like she was at the pool with friends and actually enjoying life on a way that make us, like very happy from seeing that, all the support from ECMO and other things that are coming can just give a chance for patients that before didn't have any. In conclusion, we can see that ECMO as a bridge transplantation has increased over the past few decades. Outcomes are better. Of course, the ideal candidate to bridge to transplant would be young individuals that will be awake, alert, breathing by their own, and be even part of their decision making. And of course, there's a lot of more studies that needs to be done to establish the predictors of successful bridge to transplant scenarios. Thank you. That's the